Over the next 4 weeks, we're going to be looking at opioids, a class of drugs originally derived from the opium poppy. We're going to talk about the history of these drugs, the science of how they work, their potential for abuse, and how we help people recover from addiction. Opioid drugs can be very, very dangerous, but they can also be extremely useful. According to one researcher, and I'm quoting, "To understand the popularity of a medicine that eased, even if only temporarily, coughing, diarrhea, and pain, one only has to consider the living conditions at the time." Until the 20th century, cholera and dysentery regularly ripped through communities, its victims often dying from debilitating diarrhea. Diseases like dropsy, consumption, ague, and rheumatism were very common. Opioids could be used to treat all of these things. But the line between useful treatment and harm is very blurry when it comes to opioids, and while they can be very effective in some respects, they can easily become deadly. The history of opioids are the topic of this week's Healthcare Triage. This episode is brought to you in part with generous support from the National Institute of Healthcare Management. Humans have known about opioids and their pain-relieving and euphoria-inducing properties for a long, long time. We've known about them pretty much as long as we've been writing stuff down, and maybe even longer than that. As far back as 3400 BC, records indicate the poppy was grown in lower Mesopotamia. Sumerians called it hul-gil, or the joy plant. By 1300 BC, Egyptians were growing fields of it, and the opium trade was in full force all over the Mediterranean world. The Greek physician Hippocrates, who you might know from his Hippocratic Oath, used opioids to treat a number of diseases. Alexander the Great brought opium to Persia and India. In the 1300s, though, opium sort of disappeared for a couple centuries in Europe. Evidently, the Holy Inquisition didn't care too much for its use. Opioids had some undesirable social outcomes like addiction and withdrawal, and besides it came from foreign lands. And during the Inquisition, anything foreign was pretty much the work of the devil. By the 1500s though, smoking opium was picking up again in Portugal. Laudanum was invented by Swiss polymath physician Paracelsus in the late 16th century. Paracelsus made his laudanum with a bunch of weird ingredients like crushed pearls and musk, but the real power of it was the potent combination of opium and alcohol. By the 1600s, England started importing opium from colonies in India. By the 1700s, the Dutch and the English were shipping it to China. The Chinese Qing dynasty emperors tried to outlaw opium use, but it was unbelievably popular. And it was extremely profitable for the European merchants who were importing the stuff to China. In fact, it was so profitable that the English were willing to go to war with China not once but twice to keep the opium trade in business. Not only did these wars allow the English to keep the opium trade open in China, they set the stage for European powers to force the Chinese to sign all kinds of unfavorable trade deals. The British got an indefinite lease on Hong Kong, for example, which they would hold on to for over 100 years, not returning the island to Chinese control until 1997. The 19th century saw a lot of advances in the science of opioids. In 1803, Friedrich Serturner in Germany discovered the active ingredient in opium, morphine. He managed to extract this active alkaloid, which allowed for much more potent opioids to enter the market. In 1827, E. Merck & Company began manufacturing morphine commercially, and in 1843, Alexander Wood figured out that you can inject morphine with a syringe. It was 3 times stronger when administered that way. These new opioid drugs had even more analgesic power, but they also had more powerful side effects, including euphoria and the addiction that could result from it. In 1895, Heinrich Dresse of the Bayer Company discovered that diluting morphine with acetals produced a drug with fewer side effects. They coined the term heroin and started producing it commercially a few years later. In the early 1900s, free samples of heroin were sent to morphine addicts by mail to help them quit. As you can imagine, this didn't work out so well. Heroin addiction grew rapidly, and in 1905, Congress banned opium use in the United States. In 1910, the Chinese convinced the British to take down the India-China opium trade. In the United States, the Harrison Narcotics Act of 1914 took aim at doctors to slow the use of narcotics. About 10 years later, the Treasury Department's Narcotics Division banned all legal narcotics sales. This didn't stop its use, though. An underground economy and drugs arose to meet the demand for illegal opium and heroin throughout the United States. These drugs would become a growing source of profit for organized crime during the 20th century. In 1973, President Nixon had the Justice Department create the Drug Enforcement Administration to bring all the power of drug enforcement into one agency. The war on drugs kicked into high gear. In the 80s and 90s, the United States tried to strangle the drug trade wherever it was flourishing, with arguably little effect. Around this time, the most recent wave of opioid misuse began. In the medical community, the belief that use of opioids to control pain might be safe and effective was gaining traction. In 1980, Dr. Jane Porter argued in the New England Journal of Medicine that only 4 out of 12,000 patients who used narcotics became addicted. Another study published in the journal Pain in 1986 said that only 2 of 24 patients who had used narcotics for years had had any difficulties. This, coupled with a growing recognition that doctors were undertreating pain, led to increased use. By 1996, the American Pain Society labeled pain the 5th vital sign. And any doctor will tell you that pain measurement became an integral part of any clinical visit. The pharmaceutical industry brought their weight to bear as well. They created and marketed new drugs and funded lobbying organizations like the American Academy of Pain Management and the American Pain Society in an attempt to ease the regulation of opioid drugs. But concerns began to arise that pharmaceutical companies and researchers were overstating the safety of these medications. In 2007, the maker of OxyContin pled guilty to misleading regulators, doctors, and patients about the risk of addiction and potential for misuse of the drug. They were forced to pay about $600 million as a result. Other narcotic manufacturers paid huge fines for questionable marketing and misleading claims about safety. In 2003, the New York Times reported that more than 20% of young adults abuse prescription pain medications in the United States. Even so, the drumbeat continued for more and more treatment of pain. Ironically, we've been here before in the United States. This is actually the 3rd wave of opioid abuse in the US. The first occurred in the late 1800s when Bayer started making heroin. It was being used more and more often for a wide variety of health problems. Huge amounts of money were being made, and misuse was rampant. Policy responded by taxing the drugs, regulating their use, and treating addiction more widely. Following World War II, the United States saw a second wave of abuse. Veterans of that war, the Korean War, and the Vietnam War were addicted in large numbers. In response, the government passed laws allowing addicts to be hospitalized involuntarily. Methadone clinics were set up, and the DEA began to respond to the drug trade. Today we face similar problems. Opioids now cause more deaths than any other drugs. People in the United States consume 99% of the world's hydrocodone, 80% of the world's oxycodone, and 65% of the world's hydromorphone. Here's the problem. Pain is real. It's undertreated far too often. But opioids are dangerous, and it's becoming clear that they don't work that well for chronic pain. We need to help people who are addicted curb their overuse and also find alternatives for people who are suffering. Healthcare Triage is supported in part by viewers like you through Patreon.com, a service that allows you to support the show through a monthly donation. We'd especially like to thank our research associates Joe Sevitz and MT and our Surgeon Admiral Sam. Thanks, Joe, MT, and Sam. More information can be found at patreon.com/healthcaretriage. We're continuing our in-depth look at the class of drugs known as opioids. How do they work? What's the science behind them? That's the topic of this week's Healthcare Triage. This episode and our entire opioid series are brought to you in part by the generous support of the National Institute for Healthcare Management. We all know that analgesia, or pain relief, is the intended use of opioids like morphine. But before we can talk about how these compounds reduce pain, we need to discuss the physiology of pain perception. Let's start with some biology. The brain and the nervous system are made up of cells called neurons. Each neuron consists of a cell body, which runs the neuron's activity. The cell body has a number of dendrites which come off of it. These are short fibers that receive signals from other neurons and transmit them to the cell body. Also attached to the cell body is an axon, a long fiber that takes messages from the cell body and sends them to other dendrites and from there to other cell bodies. Axons can also end up in other tissues, like muscles, transmitting commands to them as needed. When nerves talk to each other, it's called neurotransmission. They do this by releasing chemical messengers called neurotransmitters across the spaces between cells, which are called synapses. The chemicals are released from the axons and are picked up by specific molecules called receptors in the dendrites. There are different receptors all over the body that send messages to your brain when they're exposed to stimuli. There are temperature receptors that tell you when you're feeling something hot or cold. Mechanical receptors let you know when you're touching something or something is touching you. There are even receptors that detect changes in pH. When stimuli are interpreted as being noxious, meaning that they could cause damage to our tissues, specialized receptors called nociceptors send signals to our brain. Nociceptors are located throughout the body, but we mostly think of them as being in the skin, the walls of organs, and deep within other body tissues like muscles and joints. So if you've ever mashed your finger with a hammer, splashed hot water on yourself while cooking, or rolled your ankle while playing sports, you can thank your nociceptors for sending a message to your brain all about the dumb thing you just did. We commonly refer to this message as pain, but nociceptors are kind of like the first leg of the journey that a pain signal takes to your brain. When we encounter noxious stimuli, like touching a hot stove, an electrical signal is sent up a primary afferent neuron to a part of the spinal cord called the dorsal root ganglion. There, electrical current causes a release of neurotransmitters that pass the pain signal from the primary afferent neuron to a secondary excitatory neuron. There are several neurotransmitters involved in pain signaling, but the major players are glutamate and substance P. The message is then sent up the spinal cord to different parts of the brain where it's interpreted as pain. One area of the brain that receives the signal is the thalamus, which helps give context to the message. The thalamus relays the message to the hypothalamus and limbic system, which help us learn from our pain and avoid touching hot stoves in the future. A downside to these parts of the brain receiving pain messages is that they can modify our behaviors and emotions about pain in ways that can be disruptive. Afraid of getting shots because of a traumatic childhood experience at the doctor's office? Yeah, that's probably not the nurse or pediatrician's fault. You can thank your limbic system for that one. So what does all of this have to do with opioids? Well, the cool thing about opioids is that they inhibit the pain signal at multiple steps in the pathway. They work in the brain, the spinal cord, and even in the periphery. In the brain, opioids have mood-altering effects, cause sedation, and can even decrease the emotional response to pain. Opioids block the signaling from the primary nociceptors to the secondary neurons. Opioids also work on neurons that descend from the brainstem to the spinal cord that function to modulate pain signals. Those descending pathways have fibers that either amplify or inhibit pain signals being sent to the brain. Opioid compounds suppress the fibers amplifying the signal and enhance the fibers that inhibit the signal. There's even evidence that opioids can work peripherally to decrease activation of primary neurons and inhibit immune and inflammatory responses to noxious stimuli. The fact is, opioid medications are so effective at treating acute pain because they attack it from every neurological angle. Let's get even more sciencey and technical for a second and talk about how opioids work with the neurons in the spinal cord. We'll focus on the area where the primary neuron is passing the pain signal to the secondary neuron. Remember, the space where the neurons meet is called the synaptic cleft. The influx of calcium ions causes the release of neurotransmitters into the synapse. Those neurotransmitters will float across the synapse and then bind with receptors on the postsynaptic neuron. This initiates a chain of events within the secondary neuron that further propagates the pain signal to the brain. There are specific opioid receptors on both the presynaptic and postsynaptic neuron. When an opioid compound attaches to a receptor on the presynaptic neuron, it decreases the amount of calcium ions that can enter the cell, ultimately decreasing the amount of excitatory neurotransmitters that are released into the synapse. Opioids binding to their receptors on the postsynaptic neuron function to decrease the response to any of the neurotransmitters being released from the presynaptic neuron. The end result? Less pain. But wait a second. Why do our nerves have receptors that respond to a compound that miraculously diminishes pain? After all, it doesn't really make sense that mammals would evolve a specific receptor for the sap of the poppy flower. Humans have known about the analgesic effects of opium for millennia, but we wouldn't really be able to explain exactly why we had opioid receptors until the 1970s. It turns out that we have a built-in or endogenous analgesic system that modulates pain signals. These endogenous opioids, like beta-endorphins, enkephalins, and dynorphins, are collectively known as endorphins, a name derived from endogenous morphine. See what they did there? So things are going to get super duper sciencey here. The beta-endorphins, enkephalins, and dynorphins interact with different opioid receptors to varying degrees, but one thing they all have in common is the tetrapeptide sequence tyrosine, glycine, glycine, and phenylalanine. or TYR, GLY, GLY, PHE. This sequence is really important because it's needed for the endogenous opioid to interact chemically with the opioid receptor on a neuron. If this is hard to visualize, think of the opioid receptor as the car's ignition, and the tetrapeptide sequence is the key. If the key fits in the ignition just right, then the opioid receptor will be activated and cause a series of changes in the neuron that decrease the pain signal. Opioid drugs and medications take advantage of this structure-activity relationship. They bind to our opioid receptors in much the same way that endogenous opioids do, but with much more powerful consequences. There are three types of opioid receptors: mu receptors, kappa receptors, and delta receptors. When activated with an opioid agonist, like morphine, hydrocodone, or heroin, they will all produce analgesia, but each one comes with an unpleasant suite of side effects that we often associate with opioid use. Kappa receptor stimulation is associated with hallucinations and dysphorias, an overwhelming sense of dissatisfaction, anxiety, and restlessness. Delta and mu receptor agonism can cause respiratory depression because opioid stimulation in the midbrain suppresses the body's ability to appropriately detect carbon dioxide levels in the body. This can cause a person to simply stop breathing for a period of time. Other unpleasant side effects of opioid drugs are sedation, urinary retention, nausea, vomiting, dizziness, and really bad constipation. One might argue that the most catastrophic side effect of opioids is tolerance, meaning that higher and higher doses are required to get the same level of pain relief. The exact cellular mechanism behind tolerance is unclear, though there are many plausible theories. In any case, opioid tolerance is the harbinger of physical dependence and addiction. And that's the topic of next week's Healthcare Triage. Healthcare Triage is supported in part by viewers like you through Patreon.com, a service that allows you to support the show through a monthly donation. We'd especially like to thank our research associates Joe Sevitz and MT and our Surgeon Admiral Sam. Thanks, Joe, MT, and Sam. More information can be found at patreon.com/healthcaretriage. You've heard me rail on Healthcare Triage about how accidents and guns are huge killers of children. But when it comes to adults, drug overdoses are a much bigger problem. In 2014, about 34,000 adults died in car crashes, and about the same number of deaths resulted from gun violence. But more than 47,000 people died from drug overdoses. This episode is brought to you in part by generous support from the National Institute of Healthcare Management. As we discussed in our last episode, opioids work to alleviate pain, and in the 1990s, when OxyContin, Vicodin, and Percocet arrived, they quickly became popular choices for the treatment of chronic pain. We shouldn't minimize the pain problem in America. A 2011 report from the Institute of Medicine argued that about 100 million people in the United States suffer from chronic pain, almost 1/3 of Americans. Pain is real, and a lot of people are experiencing it. But treatment of pain with opioids can be more harmful in the long run than living with the pain. Worldwide, somewhere between 26 and 34 million people abuse opioids. More than 2 million of them are Americans who are abusing prescription opioids, and nearly 500,000 more are abusing heroin. Research shows prescription opioid abuse is associated with heroin abuse. In 1991, about 76 million prescriptions were dispensed for opioids in the United States. By 2011, this number had peaked to 219 million, pretty much a tripling of prescriptions. With this massive increase in prescriptions, the number of bad outcomes increased as well. Emergency room visits for abuse of prescription opioids went from 145,000 in 2004 to almost 306,000 just 4 years later. Admissions for the treatment of abuses of prescription opioids constituted about 1% of admissions in 1997, and they made up 5% of admissions a decade later. In 1999, about 2,000 people died from heroin, and about 4,000 people died from prescription opioid painkillers. By 2013, the numbers had increased to more than 10,000 for heroin and almost 19,000 for opioids. The problem, of course, is that the same thing that makes opioids powerful is the same thing that makes them so dangerous. They act on the same parts of the brain as heroin and morphine, and if used improperly, i.e. snorting or injecting, the euphoric effects are significantly increased. The numbers are a problem too. If the estimates of 100 million people suffering from chronic pain in the United States are accurate, and we treat many of them with opioids, as was the case, then even if a small percentage of these people became dependent on them, we're talking about a lot of people. In the last episode, we discussed how opioids work to reduce pain, but they also produce a sense of pleasure and well-being. People who experience this sensation tend to like it and want to experience it again. Some formulations of opioids, especially extended release forms, try to minimize this effect. Unfortunately, some people try to get around that by using the drugs in inappropriate ways, again, crushing, snorting, injecting. Because the extended release forms contain higher doses, this places people at even higher risks of complications. Tolerance is a problem as well. With repeated use, opioids lose potency, and users are tempted to increase the dose. This increases the euphoric effect and leaves them more likely to become addicted. Addiction is defined as the compulsive seeking and using of drugs in spite of terrible consequences. Why some people succumb to addiction and others do not is still a point of debate. Some believe that about half of this variability is due to genetic factors. The other half of determinants are more environmental, including mental health, socioeconomic status, and stressors. Although it was debated for some time, it seems to be more and more clear that the increase in the use of opioids has also resulted in an increased use of heroin. Especially among younger adults, there's been a significant increase in the use of heroin nationwide. Heroin is cheaper than opioids in general and easier to buy in some communities. The number of heroin users in the United States almost doubled between 2005, when 380,000 people used it, and 2012, when 670,000 did. And of course, with heroin being illegal and unregulated, it can be contaminated with other drugs, and it's much easier to overdose. When it's used intravenously, it also leaves users at risk for HIV, hepatitis, and other bloodborne diseases. We've been very liberal with our use of opioids. Some reports in pain management settings show that more than 90% of patients treated were given opioids for their chronic pain. But pain management clinics account for a small number of total prescriptions. About 20% of patients in primary care settings were longtime users, and more than 60% received opioids from their primary care provider. Many chronic users were prescribed at least 2 different opioids from at least 3 different providers. Even safer prescriptions carry significant risk. Data from the CDC show that about 80% of prescribed low doses of opioids from a single provider still accounted for about 20% of overdoses in the United States. Patients receiving high-dose prescriptions, still from a single provider, still account for an additional 40% of overdoses. The typical drug-seeking patient who sees multiple doctors and tries to fool them in order to get more drugs accounts for only 40% of overdoses in the United States. There appears to be little evidence that long-acting opioids are better for pain control with less risk for abuse. Many people believe this, though. There's a growing sense that their use leads to quicker escalation to high-dose therapy. It appears that the world is waking up to the problem, though. Recent studies highlight a recognition that opioid abuse is associated with a significant increase in mortality in people in the United States. More and more policymakers are focused on the problem and trying to find solutions. But in the meantime, we need to focus on how to treat those who already have a problem. That's the topic of next week's Healthcare Triage. Healthcare Triage is supported in part by viewers like you through Patreon.com, a service that allows you to support the show through a monthly donation. We'd especially like to thank our research associates Joe Sevitz and MT and our Surgeon Admiral Sam. Thanks, Joe, MT, and Sam. More information can be found at patreon.com/healthcaretriage. It's important to stress the difference between dependence and addiction. Dependence is the tolerance one develops over time and the withdrawal one suffers after stopping a drug. Addiction is a behavioral disorder that refers to the desire a person feels for the effects of a drug and the loss of control over their lives that they have in order to obtain it. Today we'll be looking at the treatment options available to those who are addicted or dependent on opioids. This is Healthcare Triage. This episode is brought to you in part with generous support from the National Institute of Healthcare Management. A drug addict unfortunately spends much of their day either high or sick. The goal of pharmacotherapy to help with addiction is to reduce the amount of time spent feeling sick without achieving the high. Unfortunately, we don't use this kind of therapy as often as we should. Part of that is economic. We expect insurers and public health groups to fund it, but the savings are realized by society at large. Asking insurers to pay for a program when the goals are a reduction in prison sentences doesn't always make sense to the insurers. Another reason is that therapy isn't well understood. Some people think that using drugs like methadone or buprenorphine is just swapping out one addiction for another. The media hasn't always helped with this perception. The best way to treat addiction is to prevent it. We all knew that too many prescriptions for opioid painkillers were being written. Policies were put in place to try and reduce the number of unnecessary prescriptions. In 2012, Blue Cross Blue Shield in Massachusetts started to require prior authorization for more than a 1-month supply of opioids in a 2-month period. In just a year and a half, this cut the number of prescriptions by more than 6.5 million pills. Another issue is that many still feel like drug addiction is a moral failing rather than a personal and public health issue. Usually treatment begins with detoxification, where we try to beat the cycle of withdrawal. It often continues with rehab, either in the inpatient or outpatient setting, often with pharmacotherapy as well as behavioral therapy. Unfortunately, therapy often doesn't stick. About half of those in rehab relapse. Behavioral treatments work to help patients learn to live without drugs, to overcome cravings, to avoid situations that could make drug use more likely, and to deal with relapses. The objective of treatment is to reduce dependence on drugs, to reduce morbidity and mortality caused by them, to improve mental and physical health, to prevent illicit behavior, and to help people re-enter society. Naltrexone is an antagonist medication, which means that it blocks opioid receptors. When someone is given naltrexone, then the opioids don't really work. It can treat both overdoses and addiction, although it's not as widely used for addiction as people don't take it consistently or tolerate it well. If you stop taking it, you can also get high soon after. Methadone is a synthetic opioid agonist, meaning that it works much like opioids do. It acts on the same receptors in the brains that the other opioids do, and in doing so relieves withdrawal symptoms and reduces cravings for the drugs. Methadone is one of the most popular forms of treatment for addiction. It's been shown in research to reduce hospitalizations and emergency department visits, but those are only the direct costs. If you also include societal costs like low productivity and crime, it's hard to argue that methadone therapy for opioid dependence isn't cost-saving. It's a full mu opioid receptor agonist. It has a slow onset of action and a long elimination half-life, something like 24 to 36 hours. A longer-acting derivative, known as levomethyl acetate, or LAM, exists as well. It is only taken 3 times a week. However, concerns about cardiac effects has made it less widely used than other drugs. Buprenorphine is a partial opioid agonist, meaning that it works both a bit like an agonist and an antagonist. It also reduces cravings and decreases symptoms of withdrawal. A number of randomized controlled trials have shown it to be significantly better than placebo. It's not clear, however, if it's superior to methadone. Buprenorphine is sometimes unfairly characterized, like many of these drugs, as synthetic heroin, but the drug is materially different than illicit opioids. One formulation, Suboxone, differs from other buprenorphine regimens in that it combines naloxone in the formulation, making a euphoric experience from either the buprenorphine or any other opioid pretty much impossible. All of these pharmacotherapy treatments have some problems, though. Demand for treatment programs is very high, and many of them have waiting lists. Access to these programs can be especially difficult in rural areas. Even after you get in, they're also very expensive. Insurers don't always pay for drug treatment programs, and many pharmacotherapy programs don't accept insurance even when it's willing to pay. Paying for office visits and medication can be a significant financial burden for those in recovery. It's important to remember that addiction leads to real changes in the brain. Withdrawal leads to real symptoms, including diarrhea, abdominal pain, nausea, vomiting, aches, pain, and changes in mood. Those are just words, though. The agony of withdrawal is very, very unpleasant, and people will do almost anything to avoid it. Finishing detox relieves the physical effects of addiction and withdrawal, but it's the social factors and psychological effects that lead people to relapse. Long-term maintenance therapy can help. Narcotics Anonymous is a 12-step program with a process to help people overcome addiction. It's abstinence-based, which means that it's opposed to the use of drugs in maintenance therapy. This can, of course, be controversial. Some counseling programs are more compatible with maintenance therapy. These can include cognitive behavioral therapies, like the SMART therapy program, motivational interviewing, and family therapy. Opioid abuse has become such a big problem that treatment is very, very important. Given the significant relapse rates, though, we need to continue to look for new and better ways to treat addiction. Overcoming the stigmas attached to treatment is a good start. Understanding addiction as a change in brain structure rather than a moral failing is essential. We also need further research and improvements in maintenance therapies and improved access to the treatments we have. We know we spent a lot of episodes on opioids recently, but they're a real problem for too many Americans. These powerful drugs have been in use by humans for a long time, and they're likely to remain a fixture on the human landscape into the foreseeable future, for better and for worse. Hopefully, a better understanding of how these drugs work, how they can help people, and how they can be dangerous will help us to get to a place where they can be used safely and for a short period of time. Healthcare Triage is supported in part by viewers like you through Patreon.com, a service that allows you to support the show through a monthly donation. We'd especially like to thank our research associates Joe Sevitz and MT and our Surgeon Admiral Sam. Thanks, Joe, MT, and Sam. More information can be found at patreon.com/healthcaretriage. Oh my God, you have got to take the flu seriously. This is Healthcare Triage News. We've covered the flu many times here at Healthcare Triage, and you can go watch all those episodes because they're all good, they're all still relevant, and they're all still accurate. Nevertheless, so much crap abounds on the internet about influenza. Last year, a record number of people in the United States died of the flu. The CDC reports that 80,000 people died. Like I said, that's a record. It's the highest number since the CDC began tracking flu deaths in 1976. The previous record was 56,000 in 2012-13. Last year was way worse by a high margin. There were a record number of hospitalizations at around 900,000. The previous record was 710,000 in 2014-15. There were 180 child flu deaths, the highest since the H1N1 flu epidemic of 2009. It's the highest number of child flu deaths in any regular season. 80% of the children who died from the flu last year were unvaccinated. Speaking of which, vaccinate your kids. Yes, last year's vaccine wasn't matched as well as many other years have been, and sometimes that happens, but every bit helps, and not vaccinating means you get no protection instead of suboptimal protection. I mean, 80,000 people died. Do you remember how much the country lost its mind about Ebola a few years ago? You know how many people caught the disease and died in the United States? None! And we were going crazy. 80,000 people. Imagine if we covered the news on influenza like we did things like Ebola. Imagine if we tallied up the deaths every day, told you about the kids who died, profiled them in the news. Would that make a difference? Because right now we're pretty much sweeping 80,000 deaths under the rug. I cannot tell you how many tweets I see from supposed experts minimizing the flu. Proper hand washing is the first and best line of defense. Not going out in the whirlwind sick will help too. But for the good of others, as well as yourself, herd immunity is also a really good thing. And the only way to get that is with immunization. We're going to put links to our older videos in the description below. Share the ones you liked the most. At the very least, it'd be good to get the word out to the nerd fighter community, but the more the better. Protect yourselves. Protect others. Protect those who can't protect themselves. I got my flu shot weeks ago. Already done. Our kids will get them soon. Go get yours. Do you like the show? Always helps if you like or subscribe right down there. And another good way for you to support the show is a subscription service called patreon.com, where you, the viewer, can directly support on anything you like $1 a month. More if you like, but if you don't want to, totally fine as well. Go to patreon.com/healthcaretriage to see how you can help. We'd especially like to thank our research associates, Joe Sevitz, Crafty Geek, and Jonathan Dunn, and of course, our Surgeon Admiral Sam. As always, go to httmerch.com to pick up good Healthcare Triage merch, and my book, The Bad Food Bible, still on sale in stores. One of the arguments you hear most often from people who don't want to get immunized against influenza is that the flu just isn't that big a deal. I mean, isn't it just a bad cold? Really? The flu shot is the topic of this week's Healthcare Triage. Look, there are a number of things the flu and a cold have in common. They both involve a respiratory system, and they both include a cough and a runny or stuffy nose. And of course, they both make you feel sick. But that's where the similarities end. Colds are caused by a variety of viruses, mostly rhinoviruses, 30 to 50%, and coronaviruses, 10 to 15%. The flu, on the other hand, is caused only by the influenza virus. Colds are defined as a short and mild illness, first characterized by headache, sneezing, chills, and sore throat. Later on, you get runny or stuffy nose, cough, and you'll feel a little bit crabby. Usually things move fast, and colds are at their worst 2 to 3 days after infection. Most people start to feel better in a week to 10 days after the cold starts, but some symptoms can last for weeks. Very few people with colds develop fevers. Influenza, on the other hand, feels more like getting hit by a truck. Influenza also comes on fast with more symptoms like fever, cough, sore throat, headache, muscle pain, stuffy nose, weakness, and even a loss of appetite. You're likely to feel much worse with the flu. A lot of people think of the flu or influenza as stomach flu. While you might have a loss of appetite or an upset stomach, the main effect from influenza is to make you achy, weak, and tired with a bad cough, fever, and congestion. Colds rarely do much more than annoy us and slow us down. I don't mean to minimize how bad you feel when you have a cold, but you can be pretty sure as to how bad it will get. Flu, on the other hand, can kill. In fact, the flu kills up to 500,000 people around the world each year. The number of people who die from colds is almost zero. While there's no cure for the cold, there actually are antiviral medications that can help the flu to go away faster. In order for these medications to work, you need to start taking them in the first day or two after you get sick. That's why it's important to talk to your doctor as soon as possible after you feel sick in flu season. Once those first few days have passed, the medications really won't do you any good. Although it's difficult to tell a cold from the flu at the beginning, the best predictors are cough and fever. Having both these symptoms has a positive predictive value of 80% in differentiating one from the other. So if you have a cough and a fever during flu season, there's a pretty darn good chance you've got influenza. Most importantly, there's a vaccine for the flu. The flu shot works. It prevents illness and it saves lives. To the research. One recent study showed that from 2010 to 2012, kids who got the flu shot had a 74% lower risk of being admitted to a pediatric intensive care unit during flu season. Another showed that getting the vaccine was associated with a 71% reduction in adult flu-related hospitalizations, 77% in people 50 and above. Studies show it's associated with the 79% reduction in hospitalizations for people with diabetes, 52% reduction in people with chronic lung disease. Giving the vaccine to pregnant women is 92% effective for preventing hospitalizations of infants with the flu. Yes, the flu vaccine changes from year to year, and it's based on a best guess as to what strains will be most prevalent this season. Some years they do a better job predicting than others, but research shows consistently that the benefits outweigh any potential harms. The CDC currently recommends that every single person 6 months of age or older should get the flu shot. That includes pregnant women and people with lots of chronic illnesses. There are some people who shouldn't get flu shots. If you have an allergy to chicken's eggs, if you've had a serious allergic reaction to a previous flu shot, if you've had the rare condition Guillain-Barré syndrome after a previous flu shot, or if you have a moderate or severe illness with a fever at the time you want the shot, you probably shouldn't be vaccinated. And you should at least talk to your doctor about it. Otherwise, recommendations say you should get it. Some people may tell you that the flu vaccine can give you the flu. It can't. The flu shot uses a dead virus to protect you from influenza. Dead viruses can't make you sick. Dead viruses can't be resurrected to cause infections. They're dead. I know there's likely someone out there who's arguing with the video right now. Maybe someone who thinks that the flu shot gave them flu in the past, but it didn't happen. If you've ever thought that a flu shot gave you the flu, you might have experienced the side effect from the vaccine. Vaccines can cause soreness, redness, and swelling where you get the shot. Some people also experience some low-grade fever and aches. That's not flu. That's just the lousy part of getting a shot, even though it's potentially saving your life. It's also possible you might have gotten sick right after the flu shot just by coincidence. Maybe you were exposed to another virus around that time, or even to influenza itself before you got the shot. When you get a shot and get sick at the same time, it's normal to put two and two together and assume that one caused the other. But once again, there's a difference between causation and association. Even if they happened at the same time, one event did not necessarily cause the other. Now, the nasal spray influenza vaccine doesn't have a dead virus. It has a live attenuated virus. But this live virus is a special genetically modified version of the influenza virus specifically designed not to cause infection. It doesn't revert back to the original virus that can cause infection. It's never happened. Not in scientific studies, nor in the millions of people who've gotten the influenza nasal spray vaccine since 2003. Still, some people worry that the nasal spray version of the influenza vaccine can come out of your nose and be transmitted to someone else. Shedding of the vaccine from the nose can occur, but the amount of vaccine virus that comes out of there is incredibly small, much less than you'd need to infect someone else. And in the many studies that have been done, transmission of this attenuated vaccine virus has only been seen in one person as far as I can tell by looking at the medical literature. One child in a study of 197 children had influenza from someone else's vaccine detected in their nose in a single day, but it never caused any symptoms. In all the other studies, no one transmitted the vaccine virus at all. Even among HIV-infected children and adults who'd be at a higher risk for infection, no one was infected. Of course, you should still wash your hands and try to stay away from close contact with sick people to avoid both cold and the flu. But the vaccine can make a big difference. As I said a few weeks ago here on Healthcare Triage, it's estimated that just 2 years ago, if we'd gotten the influenza vaccination rate up to 70%, we could have prevented 4.4 million illnesses and 30,000 hospitalizations in the United States alone. There's a reason the CDC recommends this vaccine for everyone. Listen to them. In 1998, an article was published in The Lancet that followed the cases of 12 children with developmental regression and gastrointestinal symptoms, such as diarrhea or stomach pain. 9 of these children had autism, and 8 of the 9 had parents who thought the symptoms of their autism had developed after the vaccine for measles, mumps, and rubella, or the MMR vaccine, was administered. This was not a randomized controlled trial, nor even a scientific study. It was merely a description of a small group of children. To be honest, it's difficult to imagine that this study could get published in The Lancet today. But based on the beliefs of the parents of those 8 children, a frenzy of fear about vaccines and autism has ensued for more than a decade. That's the topic of this week's Healthcare Triage. Let me start with some caveats. I'm a pediatrician and a health services researcher. I see kids with autism. I treat kids with autism. I've even been part of funded NIH research to improve the ways we screen for and diagnose autism in children. It's a real condition that is increasing in prevalence and has a significant impact on children and families across the world. I do not deny in any way that we need to do more about autism, but it has nothing to do with vaccines. And every dollar that we waste on that topic is a dollar we can't spend on important research or treatment to help children with autism and their families. The initial article I mentioned in The Lancet was not a study. It had no real statistics and proved no association or causation. But it caused so much concern that it led to a whole bunch of real studies to combat it. Just 1 year later, in 1999, a study was published in the same journal. No difference was seen in the age of diagnosis for those who did and did not receive vaccines. That meant that either there was no association between MMR and autism, or that it was too weak an association to be detected even in a larger sample of children. Some were unimpressed. They still were concerned. In 2001, a study was published in the Journal of the American Medical Association that looked at data on over 10,000 kindergartners born in California from 1980 through 1994. The incidence of autism over that time increased from 44 per 100,000 births to 208 per 100,000 births. That's a 373% increase. MMR coverage, on the other hand, rose from 72% to 82%, a relative rise of only 14%. It was determined in this study that the relatively small increase in MMR could not possibly be responsible for the huge increase seen in autism. The next year, in 2002, a study was published in the New England Journal of Medicine that followed all children born in Denmark from 1991 through 1998. They obtained data on over 537,000 children born in those years. They could find no association between the development of autism and the age of vaccination, the time since vaccination, or even the date of vaccination. That same year, a similar study was published in the journal Pediatrics. It followed over 535,000 children in Finland, born between 1982 and 1986. It too could find no association between the MMR vaccine and autism. In 2004, The Lancet published another study, which matched 1,294 kids with autism against 4,469 kids without it. They found no relationship between the MMR vaccine and autism. In 2004, 10 of the 12 authors of that first Lancet paper retracted the supposition that the MMR vaccine could cause autism. This kind of thing is unbelievably rare in the medical literature. An 11th author cannot be contacted before the retraction. Only one researcher, the main one in fact, held firm. For the record, that researcher is no longer licensed to practice medicine in the United Kingdom. In 2005, a systematic review or study of studies examining the effectiveness and unintended effects of the MMR vaccine was published in the Cochrane collaboration. They identified 31 studies which met the criteria for their review. After a thorough investigation, even though the MMR could be associated with a number of side effects or other issues, there was no evidence for an association between the vaccine and autism. And in 2012, they updated their work. This time, the research they found included 5 randomized controlled trials, 1 controlled trial, 27 cohort studies, 17 case control studies, 5 time series trials, 1 case crossover trial, 2 ecological studies, and 6 self-controlled case series studies. All of these together involved about 14,700,000 children. And in all that data, they could find no link between vaccines and autism. Because there is no link. And another study, no matter how many times you ask for one, isn't going to overcome this massive amount of data. Humans try to make sense of the world by seeing patterns. When they see a disease or condition that tends to appear around the time a child is a year or so old, as autism does, and that is also the age that kids get particular shots, they want to put those things together. Parents watch kids more carefully after they get shots. Sometimes they pick up on symptoms then. But just because 2 things happen at the same time doesn't mean that one caused the other. This is why we need careful scientific studies. And as I've outlined here, there have been many such studies that have failed to find any real evidence to support the hypothesis that vaccines cause autism. And don't tell me it's the mercury in thimerosal that's to blame. There has been no thimerosal in infant vaccines since 2003, and autism hasn't disappeared in the last decade. This was all because of one paper, a decade and a half ago, that described the beliefs of the parents of 8 children with autism. And that's what makes the next part in this all the more tragic. In 2011, the British Medical Journal released an article which described in detail how that 1998 Lancet paper wasn't just junk science, it was a lie. It described how the main author, the only one who still supports its findings, changed the records, changed the stories, and changed the numbers to create the appearance of an association where none existed. The journalist who wrote the BMJ article tracked down the patients in the study and showed how none of their stories or information matched up to what was published in the final paper. He found that there were discrepancies as to whether the children actually had regressive autism. He found that there were falsifications and other symptoms that were alleged to cause the autism. He even discovered that dates had been changed. Although the Lancet paper alleged that 8 of the 12 patients reported symptoms days after the MMR vaccine, the BMJ investigation confirmed that for almost all of these children, that wasn't the case. And if that wasn't bad enough, it turned out that all of the patients had been recruited by anti-MMR campaigners. The study was also commissioned and paid for by a group that planned litigation against the vaccine manufacturers. The British Medical Journal called the original Lancet paper a fraud. It's easy to become cynical about people's loss of trust and understanding in science, to the point that you think it's unlikely that we will ever be able to convince some people that the MMR vaccine is safe. That's a tragedy in and of itself. It's easy to believe that the perpetrator of this fraud will not suffer the repercussions he deserves. Many still continue to lionize him and believe him to be a victim of some powerful cabal. It's hard for me to be dispassionate about those who abuse the trust people give physicians. I get even more riled up when someone violates the rules of ethical science. I think it's likely that children have not been given an MMR vaccine because of this fraud. I think it's likely children have gotten sick because of this fraud. I think it's likely some children have died. I hope we can find some way to change that in the future. This episode of Healthcare Triage is supported by Audible.com, a leading provider of premium digital spoken audio information and entertainment on the internet. Audible.com allows its users to choose the audio versions of their favorite books, with a library of over 150,000 titles. We recommend The Signal and the Noise by Nate Silver, which explains the analysis of data and statistics in an entertaining and informative manner. It's great. You should go listen to it now. You can download an audio version of The Signal and the Noise or another of your choice at audible.com/triage.